Welcome. We're going to have a short video discussing the EFAST. Now, the FAST has been known as the Focus Assessment with Sonography and Trauma. The EFAST adds the word extended, so it's the Extended Focus Assessment with Sonography and Trauma. This is one of the earliest EM focus applications for point-of-care ultrasound. Over time, the use has been expanded throughout penetrance into emergency medicine and other areas. And as you can see, even ATLS has caught up, where the DPL is no longer mandatory but optional, and the FAST can be used as a replacement skill station. Now, there's practice guidelines for the performance of the FAST, and this is a guideline provided by the American Institute of Ultrasound and Medicine in cooperation with the American College of Emergency Physicians. The FAST exam will be performed with a curvilinear or a phased array probe in an abdominal preset. Abdominal preset means that the indicator will be pointed towards the patient's head or towards their right side. Our first view is going to be a subxiphoid view, indicator pointed towards the patient's right side. Then we're going to do an IVC view, which is a sagittal view of the IVC as it goes through the liver to enter the right atrium, indicator towards the patient's head. A coronal right upper quadrant, indicator towards the head. A coronal left upper quadrant, indicator towards the head. We are then going to do a sagittal view of the pelvis, indicator towards the head, and then a transverse of the pelvis, indicator towards the patient's right. Our final views are going to be sagittal views at the second intercostal space in the midclavicular line, looking for the presence or absence of pneumothorax, and we're going to do the right and left chest. So in another schematic presentation, first view is subxiphoid, indicator towards the right. Second view, IVC, indicator towards the head. Third view, right upper quadrant, indicator towards the head in a coronal plane. Fourth view, left upper quadrant. Fifth view, pelvis sagittal. Sixth view, pelvis transverse, and then seventh view is the intercostal sagittal planes for pneumothorax. Our FAST is the subxiphoid, right upper quadrant, left upper quadrant, and two views of the pelvis. The extended portion of the FAST adds the IVC assessment and the lung views for pneumothorax. The basis of the FAST exam is that natural anatomic structures are rounded and curved. The basis of the FAST exam is that anatomic structures are rounded and curved in the body, and we do not have right angles generally. When two rounded structures are abutting each other, there are sharp angles in between them. So when we see anechoic areas of fluid, they will have sharp corners as they are between anatomic structures, compared to fluid within anatomic structures, which is rounded and curved without those sharp angles. So what we are looking for is the presence of free fluid, which would be anechoic with sharp angles because they are outside anatomic structures. Our first view is going to be that subxiphoid view, indicator towards the patient's right, shooting through the liver to the heart. And what we're looking for is a view through the liver to the heart, both right and left-sided structures. And we're looking for the presence of cardiac activity and the presence or absence of pericardial fluid. So we're going to see the liver, we're going to see the diaphragm, the right-sided chambers, and the left-sided chambers. We'll also have some view of lung and lung artifact in this view. And this is what your view is going to look like. You're going to see the liver and you're going to see the heart, shooting from an inferior towards superior portion, and we're going to look for cardiac activity and presence or absence of pericardial fluid. Here's another view where we're using a curve array, shooting through the liver to the heart, and you can see there's a little bit more gas artifact here, both from the stomach and from the lung. And what we're looking at is the liver, the stomach, with air artifact from an air-filled stomach, the diaphragm, right-sided chambers, and the left-sided chambers. We also see some mirroring artifact because of aerated lung. And here's a view where we can see a pericardial effusion with the anechoic layer separating the heart and the pericardium is abutting the diaphragm as one continuous line. Here we can see another sample where we have pericardial fluid. Here we can see another example where we have pericardial fluid and a pericardial effusion. We also see the presence of pericardial clot within that pericardial space. Here we see pericardial effusion. However, this is concerning because the pericardial effusion is actually impacting cardiac function. We see that the right-sided structures, both the right atrium and the right ventricle, are not contracting normally. Instead, they have this undulating or collapsing effect, and that's because of the pericardial fluid inducing a tamponade physiology. Here we see lack of cardiac activity where we can clearly see the heart and there's no contraction of the heart. So once again, we're looking at our subxiphoid view and we're shooting through the liver to the heart. If you have a large amount of stomach gas, you see where the probe is located. You can slide towards the patient's right to try and image through the liver and avoid the stomach bubble. However, if there's a lot of bowel gas degrading your view and limiting your window, your other option is to move up onto the chest and obtain a sagittal view of the heart or a parasternal long axis. And in that, we're looking at the heart here, where we're looking for these structures. We're going to mainly see the left-sided left atrium, left ventricle, with a small amount of right ventricle in view. Now, we won't go into heavy detail on the parasternal long view, as that is covered in our echo lecture. But this is an alternative view where you can see the cardiac activity and presence or absence of pericardial fluid should your abdominal window be limited. We can see a posterior pericardial effusion with that anechoic wedge separating the heart and the pericardium. Here you can see a pericardial effusion in the parasternal long view surrounding the heart, and it is actually impacting cardiac function. You can see the right ventricle having some impaired contraction. Our next view from the subxiphoid is going to rotate the probe to be a sagittal plane, indicator towards the patient's head. And from that midline view, our next view is the IVC view, where we're going to rotate the probe to have a sagittal view. And while imaging at the midline, we're going to tilt the probe slightly to the patient's right to image the IVC, which is just to the right of midline. And you can see here, we convert from that subxiphoid view to image through the liver to the IVC as it enters the right atrium. And this is what we're looking for. We're looking for the IVC traveling through the liver to confirm that it is the IVC and as it enters the right atrium. Those two anatomic boundaries allow us to identify the IVC reliably, meaning it travels through the liver and connects to the right atrium. We'll see the liver itself, the diaphragm, the IVC, the right atrium, the right ventricle. Here you can see a view where we're seeing the IVC running through the liver. We see liver in the near field and the far field, and you see how it connects to the right atrium. Here's another view where we can clearly see the IVC running through the liver to the right atrium, and you can see some respiratory motion as the patient breathes. The IVC collapses, denoting a lower preload than the previous example where the IVC did not collapse. So what we're looking for in this view to make sure we are identifying the correct structure is liver on both sides of the IVC, meaning the IVC runs through the liver, not behind it like the aorta. And we're looking for the right atrium, which then lets us identify this tubular anechoic blood vessel as the IVC. And you can see here, well-inflated IVC versus a very flat IVC. And that's where we're looking for the presence or absence of a flat IVC to denote preload, so we can get a sense of preload and volume status should we have a hypotensive, traumatically injured patient. Our next view is going to be the right upper quadrant, and this is a coronal view shooting from lateral to medial with the indicator pointed towards the patient's head. Now, one concern is that the ultrasound beam is very thin, somewhere between 1 and 1.5 millimeters in thickness. So when we're imaging in the right upper quadrant, we are only getting a very small slice. We have to image the entire right upper quadrant, looking in the lower thoracic cage, looking in the right upper quadrant around the liver, around the kidney, and in the paracolic gutter. So while this is a very thin beam and a very thin section, there's a large area to view. Just like you would not look at a single CT scan, you would not look at a single image from the right upper quadrant. Instead, we're going to have to scan through the entire area to get an idea of what's going on in this three-dimensional structure based on our two-dimensional image. So we're going to start in the posterior area, and we're going to come anterior, and we're going to move throughout the interface and move anterior and posterior, scanning through the entire three-dimensional area to get our information. This is one of our cardinal views of the right upper quadrant, and you can see we're imaging from lateral, seeing the ribs, to medial, seeing the spine. We're looking at the liver, the kidney, the inner space between the liver and the kidney, the hepatorenal space, or Morrison's pouch as it's commonly known. We're going to identify the spine and the spinal stripe as a hard landmark. We want to also identify the diaphragm and the lung. And we want to look at fluid between the lung and the diaphragm and between the diaphragm and the liver. Now, unfortunately, there is a major artifact that you'll see here. The diaphragm is a specular reflector. So what happens is sound beams leave the probe, impact the diaphragm. If there's aerated lung above the diaphragm, it reflects very well, and that sound beam is reflected into the liver. That sound beam hits liver tissue, and then that sound beam is then redirected to the diaphragm and reflected back to the probe. However, the ultrasound machine assumes sound travels in a straight line, so all of that sound is then plotted out in a straight line, and it assumes that liver is now above the diaphragm. This is called a mirroring artifact because the area above the diaphragm is mirrored from the area below due to the reflection. This is a normal artifact that will tell you there is aerated lung above the diaphragm. And you can see this because the spinal stripe stops at the diaphragm, and as we all know, the spine does continue past the diaphragm, but what we see above the diaphragm is the absence of the spinal stripe and the presence of what appears to be liver. And if you look closely, the liver matches on both sides of the diaphragm with hepatic vessels noted on both sides. You can see the spinal stripe stops there right at the diaphragm, and we see this area mirroring there showing what looks like liver above the diaphragm. This tells me that there is aerated lung opposed to the diaphragm or normal interface. Here's another example of the right upper quadrant, and this is what we're looking for in the upper part of the right upper quadrant. Now, the entire interface in the right upper quadrant may not be able to be obtained in a single video clip or single scan through, and you may need several video clips to capture all the parts. What we're looking for is the liver, the kidney, the hepatorenal space or Morrison's pouch, and here we can see the upper portion of it, but not necessarily the inferior portion. We're looking for the spinal stripe, or this bright corrugated hyperechoic line that denotes the spinal bodies. It ends at the diaphragm, which we can see here, and beyond that we see mirroring, telling me that there's no fluid above the diaphragm. We're going to image a little more inferior here, and we're also looking for the liver, the kidney, Morrison's pouch, and here we're looking at the mid and inferior portion of Morrison's pouch that we cannot see because of the size of the liver in order to get a clearer view of the diaphragm. We will see the spinal stripe here as our hard landmark. We do see part of the diaphragm, but we don't see above it as well. And here we can see as we're scanning through, we're looking more at Morrison's pouch, seeing that hepatorenal interface a little more clearly. And you can see as we slide more inferior, we're getting a better view of that distal portion. Here we can see a lot more of that area, and we're also evaluating the inferior pole of the kidney, which is the paracolic gutter. When you see mention about imaging the paracolic gutter in the FAST exam, what they're really talking about as a hard landmark is the inferior pole of the kidney. You will also see that we've evaluated the entire hepatorenal space as we see the liver tip. Now this may be anterior where you're seeing some bile gas pattern, and normally we try to avoid the bile gas because that tells us we're intraperitoneal versus the hepatorenal space with the kidney being retroperitoneal. What we want to identify here is the liver, and there's going to probably be some loops of bowel. And what we're looking for as we slide inferior and anterior is that inferior tip of the liver. And the reason being is fluid will begin to collect at the paracolic gutter, at the inferior pole of the kidney, or the inferior tip of the liver before that fluid begins to track into the hepatorenal or Morrison's pouch. You will see the inferior tip of the liver, which is the beginning of the hepatorenal space, and the paracolic gutter. Small amounts of fluid will collect here before it begins to dissect or track through Morrison's pouch. So if the patient is very early in their course or has been transported very quickly or has very small amounts of fluid, you can miss it if you do not evaluate the inferior pole of the kidney and the inferior tip of the liver. You can see here an example of free fluid. You see anechoic areas with sharp corners in between the liver and the kidney. However, you see a lot more fluid accumulating in the paracolic gutter near the inferior pole of the kidney and the inferior tip of the liver rather than superior between the liver and the kidney. So you can see that a lot more fluid accumulates in this area before it tracks into Morrison's. So if you're not evaluating the entire right upper quadrant, you may miss small amounts of fluid. Here's an example of a large amount of free fluid separating the kidney and the liver in Morrison's pouch or the hepatorenal space. Here's another example with fluid in Morrison's pouch, and you can see it's anechoic with sharp angles. Because remember, anatomic structures are rounded, and when you have two rounded structures next to each other, that space will then have sharp points. Here's a view where we no longer see mirroring, and what we're seeing is fluid above the diaphragm. You can see the spinal stripe extends. The spinal stripe does not end at the diaphragm, highlighted by this arrow. It instead extends past it. And what we're seeing are the findings to diagnose a pleural effusion. We see extension of the spinal stripe. We see an absence of mirroring. And we see anechoic fluid above the diaphragm. With those three findings, we do have pleural fluid. And if it is a traumatically injured patient, we are concerned about a hemothorax. The next step is the left upper quadrant, which is going to be similar to the right. However, we have the splenorenal space rather than the hepatorenal space. Now, a difference between the left upper quadrant and the right upper quadrant is that fluid tends to accumulate around the spleen rather than between the spleen and the kidney. And this is because of the vascular hilum of the spleen, which keeps it close to the kidney. Instead, we're going to see more fluid around the spleen, such as between the spleen and the diaphragm and near the inferior pole of the spleen, compared to the right upper quadrant, where the liver is held to the diaphragm by the coronary ligament, and we'll see more hepatorenal fluid. What we're looking to identify is our spleen, our kidney, the splenorenal space, our spinal stripe, and the diaphragm. We also want to get a view of above the diaphragm, viewing lung or mirroring artifact, just like we do in the right upper quadrant. And remember, just like in the right upper quadrant, because of the aerated lung, we will have a specular reflector in the diaphragm and we'll have mirroring artifact, making it appear that there's spleen above the diaphragm. Another difference you'll note when imaging the left upper quadrant in the FAST exam is that the left upper quadrant views will be slightly more superior and posterior compared to the right, likely one interspace higher and more posterior. So what you want to do is when you reach over from the patient's right side, you want to maintain your probe parallel to the bed and touch your knuckles to the bed as you slide in for the left upper quadrant and then work your way anterior. We see here the left upper quadrant, we can see our spleen, spinal stripe, diaphragm, and our splenorenal space. Very nice view of the spleen and diaphragm space, as we're going to see fluid accumulating around the spleen much more than between the spleen and the kidney. Once again, we're seeing mirroring above the diaphragm. We're getting a good view between the diaphragm and the spleen, and we're seeing the splenorenal space itself. Here's your left upper quadrant view, and what we're looking to identify is the spleen itself, the kidney, the splenorenal space, the spinal stripe that ends at the diaphragm and does not extend past it, the diaphragm itself, and mirroring artifact. This allows us to evaluate for presence of fluid between the spleen and the diaphragm and around the spleen. The other area that you also want to evaluate is the inferior pole of the kidney and the tip of the spleen. Once again, fluid will accumulate near the spleen tip rather than in the splenorenal space in early phases. And you also want to evaluate the paracolic gutter, which you denote by the presence of the inferior pole of the kidney. So there is the spleen tip, looking for fluid there. And you can see in this example, we have free fluid. We have anechoic areas in the near field, sharp corners, and we see it around the spleen near the spleen tip rather than in the splenorenal space. We also have very subtle free fluid here with fluid collecting around the spleen tip. And you can see that anechoic border there. And you can see here highlighted where you have that anechoic wedge and just a very small amount in the left upper quadrant surrounding the spleen tip. If you do not evaluate the inferior pole of the solid organs, you may miss small amounts of fluid. Here you can also see near the top of the spleen there was some free fluid with anechoic areas and sharp corners that you may have missed on the initial scan. Next, we're going to start with our sagittal view in the pelvis. And remember, we're not imaging the bladder. The bladder is a landmark, and we're imaging for the spaces around the bladder, looking for free intraperitoneal fluid. The reason we start off in the sagittal view is because it is easier to evaluate for free fluid behind the bladder and solid organs, and the fluid will be tracked towards midline. The other reason is that if the bladder is decompressed, you may have some difficulty finding all of your landmarks. Rather than trying to differentiate bile gas and decompressed bladder, starting the sagittal view allows you to identify the pubic symphysis as a bony landmark. After the pubic symphysis, we're going to identify some landmark organs. If it is a female patient, we're going to identify the vaginal stripe, then the bladder, uterus, and we're looking for fluid in the anterior cul-de-sac and the posterior cul-de-sac. If it is a male patient, we are still looking for the pubic symphysis as our hard target bony landmark, the bladder, the retrovesicular space, and we also want to identify the prostate. And as we're scanning through, we can see the bladder, and we do have some posterior acoustic enhancement because the bladder is filled with fluid. So you may have to adjust your far field gain in order to differentiate tissue layers and pick out free fluid. One of the common errors is that gain is not adjusted and the posterior field deep to the bladder is overgained and you miss free fluid because of the overgaining and the bleed through of echoes. Once again, we're looking for the pubic symphysis, bright hyperechoic line showing the bony structure with posterior acoustic shadowing. Now, when we're looking at the area around the bladder, in this male patient, we can see the prostate. This area of the bladder wall and the area posterior to it shows the prostate in the pelvic floor. Remember, this is not the intraperitoneal area. This area is the intraperitoneal area where we're looking for free fluid. So you need to make sure you're imaging the top of the bladder. So as we're scanning, now this person is scanning a little fast. You want to scan a little slower because remember, you're not just acquiring the images, you're acquiring the images and interpreting them at the same time. Once again, as we scan from lateral to lateral in a sagittal view of the pelvis, we're looking for fluid around the bladder, making sure we're catching that superior border of the bladder. If the bladder is distended, you may have to scan the bladder in two portions, catching the inferior portion and the superior portion in two separate sweeps. You can see here in a female patient, you're going to evaluate around the uterus in both the anterior and posterior cul-de-sac. If the patient is pregnant, you will note that there is an intrauterine pregnancy. However, do not get distracted by the presence of the intrauterine pregnancy. You still have to evaluate through the whole interface looking for the presence or absence of free fluid. Here you can see a patient with a large amount of free fluid, making it difficult to find and identify all the anatomy. Here you can see a more common finding where you see the bladder and you see anechoic fluid with sharp angles in the anterior and posterior cul-de-sac around the uterus. This shows the presence of free fluid in the posterior field. You can see some free fluid deep to the bladder, anechoic with sharp angles. However, the posterior acoustic enhancement has not been accommodated for and far field gain has not been decreased, making that anechoic area appear to have echoes within it. You can also note there are echoes within the bladder showing that it is slightly overgained. To compensate for this, you would have to decrease far field gain to make that fluid appear anechoic. Our next view is going to be a transverse view of the bladder, meaning indicator towards the patient's right. And once again, we're going to look for the bladder. We're going to look for the retrovesicular structures such as the uterus. We're going to obtain a transverse view identifying the bladder. In the transverse view, the bladder is somewhat square or rhomboid shaped, making it easier to differentiate from free fluid or cysts. We're going to identify the retrovesicular structure, whether it's the uterus or the prostate. In this case, in a male patient, it will be the prostate that we see. And then we're going to scan from inferior to superior, looking at the lateral portions of the bladder. You may be able to see fluid in the posterior area to the bladder. The transverse view makes it easier to identify fluid lateral to the bladder that may have been missed in the sagittal plane. Once again, the bladder does appear somewhat square to rhomboid in shape, making it easy to identify rounded corners with a wall. And as we scan through, we are going to see the uterus pop into view if it is a female patient. And once again, we're looking lateral to the bladder and lateral to the uterus for free fluid that may have been missed in a sagittal plane. And once again, if you identify intrauterine pregnancy, return to it to evaluate it further if need be, but however, do not get distracted by it and forget to complete your scan. Here you can see the rhomboid-shaped bladder, and as we scan through, we note a large amount of free fluid, anechoic, sharp angles surrounding the uterus in both the anterior and posterior cul-de-sac. Here you can see the uterus with free fluid posterior, the broad ligament, and the bladder anterior. You can see that the bladder has that rhomboid shape with a wall to it, whereas the posterior area has those sharp angles without a clear wall. Here you can see another example where posterior acoustic enhancement has not been compensated for and the posterior field is overgained. You are unable to differentiate tissue layers and you would not be able to identify any free fluid in the far field. Our next view is going to be the intercostal view, looking for the presence or absence of pneumothorax. We're looking in the mid-clavicular line at the second intercostal space, right where you would needle decompress, and we're looking for the presence or absence of pneumothorax. Now remember, we are looking for large pneumothoraces that would impact our care in the trauma bay and need immediate decompression or treatment, not necessarily small pneumothoraces that can be evaluated further. With ultrasound, we're evaluating for the presence or absence of pneumothorax under the probe, meaning we are looking in a single spot for the presence or absence of pneumothorax, not excluding it throughout the entire thorax. What we want to do is identify our key landmarks. We're going to identify 2 ribs, and we're going to look at the pleural line in between to get a view of what's going on with the lung. However, there is going to be a large amount of air artifact, which is the hallmark of lung ultrasound, and what we're paying attention to is the pleural line between the 2 ribs. You want to identify 2 ribs so you can have anchoring landmarks to identify the pleural line in between. We're looking for our 2 ribs here, and we're looking for that pleural line in between the 2 ribs. You want to center on the pleural line, not on the rib. And what we're looking for is what's called lung sliding or pleural sliding. And as the person is breathing, you can see that pleural line sliding back and forth with a shimmering or sliding effect. And this is what we're looking at. In the far field, we're looking for the presence or absence of B-lines, but however, we are focusing on the intercostal space and the pleural line there, looking for sliding, telling us that there is normal aerated lung, or no sliding, telling us the presence of a pneumothorax. Here's another view with a linear probe showing the 2 ribs and the pleural line sliding back and forth at a little higher resolution. Here's another view where we're seeing lung sliding with the curvilinear probe. And what we want to do is turn off post-processing, meaning turning off compound imaging or multibeam and harmonic imaging. And you can see that the pleural sliding is much clearer when these post-processing things are turned off. They try to suppress artifacts and may reduce sliding. If you are unsure if you see lung sliding with these items on, be sure to turn off both harmonic and multi-beam or compound imaging to highlight sliding to ensure that there is lung sliding or no lung sliding. The other option to evaluate for lung sliding is the use of M-mode. And what happens is you evaluate the pleural line, you drop your M-mode spike through it, and you're looking at the M-mode tracing. And this allows you a better view of presence or absence of lung sliding. So if you see lung sliding clearly on B-mode or 2D imaging, you don't have to do M-mode. However, if you are unsure, that's where M-mode will come in handy to help you differentiate. You drop the M-mode spike through the pleura, and what happens is everything along that M-mode spike is plotted over time. So you see that single line plotted over time on the x-axis. Everything along the M-mode spike would be plotted over time, so the chest wall, which is not moving, appears as straight lines as there's very little to no movement, whereas the lung and the pleural line, which has a lot of movement and artifacts, shows this textured appearance over time. This is called the seashore sign, as it looks like there is beach and water. So along this area, you see the pleural line there, you see the chest wall and the lung. Now, the chest wall shows you no movement, so there's a linear pattern, whereas the lung shows you movement, causing that speckled appearance. Here you have another example of lung sliding, and what we can see here is the pleural line. We see the chest wall and the lung, and no movement in the chest wall versus movement in the lung. So once again, we're going to get our view of the pleural line anchored by 2 ribs on either side. We're going to drop our M-mode spike, and we're going to get our M-mode tracing showing lung sliding or the seashore sign. Here we have our 2 ribs anchoring the view and our pleural line between them. And you see that that pleural line is not shimmering or sliding back and forth. This is a patient with a pneumothorax with no sliding. Here you can see another example, 2 ribs, pleural line in between with a lot of reverb artifact from free air within the hemithorax, and we have no sliding at the pleural line, and we have a pneumothorax. Here's another example. Every time the person tries to breathe, you do see the chest wall move slightly. However, you do not see the pleural line sliding. This patient also has a pneumothorax. If we were to drop an M-mode spike through that, you see the linear pattern of no movement in the chest wall, the pleural line, and a matched view of no movement below the pleural line, showing you absence lung sliding and a pneumothorax, also referred to as a stratosphere sign. Here's another example of pneumothorax. You can see the pleural line. There is a little blip where the chest wall is moving, causing movement throughout the field and not just in the lung. Here you can differentiate between the two with lung sliding present on the left of your screen and pneumothorax present on the right. You can see the textured pattern of movement on the left below the pleural line versus on the right below the hyperechoic pleural line. There is no movement either above or below it. This is a finding that's called a lung point, where you have an area of pneumothorax, and as the patient inspires, the lung inflates and you see some aerated lung slide into view. So you see lung sliding appear and disappear. This is at the very edge of the pneumothorax where the aerated lung is moving into view. This tells you that there is a pneumothorax and this is the border. So when we are doing our EFAST exam, we're going to start off with the subxiphoid view, followed by the IVC, followed by the right upper quadrant, left upper quadrant, pelvis and sagittal, pelvis and transverse, and anterior thorax for pneumothorax evaluation. The reason we go in this protocolized order are severalfold. First, you want to look at the heart. If the heart is not beating, very little other information in the abdomen is going to be as helpful. You also want to view the heart as you have blood within the cardiac chambers, and you have a standardization of setting your gain for free fluid. Also, as we progress through these views, we are going to decrease the amount of gain and decrease our depth, working our way from the subxiphoid to the lung. So this way you are continually decreasing depth and decreasing gain rather than bouncing back and forth between increasing and decreasing both values, making for a smoother and more efficient scan. Don't forget to subscribe and follow. Links are in the description below.